Today we are having the third session of the webinar series, and the topic is an approach to vesiculobullous disorders of skin. Usually being a general pathologist, histopathologist, reporting a case of classic vesiculobullous lesion is a great relief compared to other inflammatory lesions. But the biopsy is not from a classic lesion. We are again in the zone. So today we have Dr. Raghavendra Rao, Professor of Dermatology, KMC Manipal, with us as our esteemed speaker to talk authoritatively on approach to vesiculobullous disorders of skin. On behalf of the IAPM Kerala chapter, I am privileged to welcome Sir to this webinar. So, Dr. Raghavendra Rao, Sir is a professor, currently the professor in Department of Dermatology, KMC Manipal, and Sir has several awards to his, most importantly, he has got the Dr. B.M. Ambadi Oration in Dermacon 2024, and Sir has been awarded the Vishnupriya Devi Award for the best original article published in Indian Journal of Dermatol Venerol Leprol in 2021 and 22. And Sir's PGs have been awarded Best PG Thesis Award. And Sir also has been awarded being the guide of the PGs in the year 2021, then in Dermacon 2019 and in E-Dermacon 2022. And Sir was awarded the Commonwealth Academic Scholarship at St. John's Institute of Dermatology, London, UK, during 2011 and 12. And again, Sir has been awarded the B.N. Banerjee Medal for the Best Original Research Paper in Dermacon 2005. And he is a past editor-in-chief on the Indian Journal of Dermatopathology and Diagnostic Dermatology. And Sir is interested in vesiculobullous diseases, pediatric dermatology, and dermatopathology. So over to you, Sir.
Thank you. Thank you very much, Madam. At the outset, I would like to thank IAPM Kerala chapter for this opportunity, led by Dr. Neena, President of IAPM, Dr. Shaini, PM, Secretary, and Dr. Deepa for this wonderful opportunity. So the topic that was given to me is approach to vesiculobullous lesions in the skin. I understand that there are many pathologists in this audience. So I'll be talking a little bit about the clinical features also, because that is important for them to correlate with the pathological features. So before we proceed, we should know what is a vesicle and a bulla. So vesicle and bulla are a cavity containing fluid which occur in the skin. If the size of the lesion is less than 5 millimeter, we call it as vesicle, like this here. And on the other hand, if the lesions are bigger in size, more than 5 millimeter in diameter, then we call it as bulla. So this is the basic understanding of the lesions of this group of conditions. So when we see these lesions in the clinic, now what does the clinician will think? So clinician, the first question that clinician will always want to know is whether the lesions are there since birth or is it an acquired condition. So vesicle and bullous lesions can be present at birth or may develop soon after birth. So in that setting, we consider the possibility of epidermolysis bullosa, which is a hereditary one, or sometimes porphyrias also. On the other hand, when we think of acquired conditions, the first thing that will come to our mind is autoimmune bullous diseases. It also could be because of drug reactions, and various other conditions such as acute dermatitis may occasionally present with vesiculobullous lesions. On the other hand, when a pathologist see a slide of these conditions, they always want to know whether it is an intraepidermal condition or is a subepidermal condition. So if it is an intraepidermal condition, then you have a set of differential diagnoses that you want to consider. On the other hand, if it's a subepidermal diseases, again, your differential diagnosis will be slightly different. So apart from the level of split, histopathology also will help us to know the mechanism of blister formation. For example, we can find out if the vesicle or bulla is erasing because of spongiosis, which can occur in cases of acute dermatitis, or is it because of acantholysis, where there is separation of the keratinocytes from each other because of loss of cohesion, so which can occur in cases of pemphigus or Hailey-Hailey disease. It also could be because of cytolysis, as it occurs in case of erythema multiforme. On the other hand, subepidermal blisters occurs because of the disruption of basement membrane zone, the classical example being bullous pemphigoid. Radical degeneration occurs in herpes, and that again can cause vesicles and bullous lesions. Histopathology also will give us information about the type of inflammatory cells. So, is it a neutrophil-rich blister, or is it an eosinophil-rich blister? That will help us in the diagnosis. Other additional findings in the form of papillary tip microabscess, which is classically seen in case of dermatitis herpetiformis, helps in the diagnosis. So the conditions which can manifest with vesicles and bulla are very vast. It will not be possible for me to cover each of them. So I will restrict myself to a broad group of conditions which are called autoimmune bullous diseases, or AIBDs. So I'll be talking mostly on these conditions in this talk today. So what are autoimmune bullous diseases? So they are a group of heterogeneous conditions which are potentially life-threatening. So that is why the rapid diagnosis of these conditions is very important for both clinicians as well as pathologists. So they manifest clinically with blisters in the skin or mucous membrane. Sometimes some patients will also have mucocutaneous lesions. Broadly, they are classified into intraepidermal condition or subepidermal bullous diseases. When we think of intraepidermal bullous conditions, the blister formation occurs within the epidermis, the classical example being pemphigus. Now, pemphigus has got several variants, such as pemphigus vulgaris and vegetans, pemphigus foliaceus and erythematosus. Paraneoplastic pemphigus occurs in the setting of internal malignancies. Drug-induced pemphigus, or a rare form of pemphigus, which is called IgA pemphigus, where the diagnosis requires immunofluorescence test. On the other hand, when the blister occurs just below the epidermis, when the cleavage is in the subepidermal plane, the prototype of these conditions is bullous pemphigoid. But there are certain other conditions which needs to be differentiated from bullous pemphigoid, such as epidermolysis bullosa acquisita, linear IgA disease, mucous membrane pemphigoid, or anti-P200 pemphigoid. So these are the examples for subepidermal conditions. Now, what is the pathogenesis of these conditions? Briefly, it's very important for us to understand what exactly happens in these conditions so that we can correlate it better, both clinically as well as histopathologically. So, a pemphigus is a prototype of intraepidermal AIBD, where the autoantibodies are target intercellular junctions such as desmoglein 1 and 3. These desmogleins are transmembranous protein, which means that a part of protein is present within the cell, but a major part is present in the intercellular junction, where it forms a scaffolding structure with the desmoglein of adjacent cells, so that they maintain the framework of epidermis. So in the disease state, autoantibodies are produced against these proteins which are present in the intercellular junction. As a result, that initiate a cascade of events which ultimately leads to internalization of desmosomes as well as separation of the desmosomes from each other, leading to acantholysis. Now, we want to demonstrate these antibodies that are present in the intercellular junctions. This can be done by direct immunofluorescence test. On the other hand, in subepidermal bullous conditions, the blister formation occurs below the epidermis, and the autoantibodies in these conditions target at least 6 important proteins that are present in the dermoepidermal junction. So these proteins can be broadly categorized into 4 different subgroups. One is you have semidesmosomal region, which is present in the basal keratinocyte, and this has 2 important proteins such as BP230, bullous pemphigoid 230, and plectins. The second zone here is upper lamina lucida, which is present here in this zone. There are 2 important antigens, BP180 and alpha-6 beta-4 integrins. In the third zone is lower lamina lucida, which is corresponding to this part of BMZ. And here again we have two antigens, so that is laminins, laminin 332 and laminin gamma 1. The fourth region is sublamina densa, which is present just below the type basal lamina or lamina densa. So this region contains another important protein which is called type 7 collagen. So these are the important proteins which are targeted in various subepidermal autoimmune bullous conditions. A quick knowledge of this is important for you to understand what exactly is happening in these conditions. So how do we make a diagnosis of autoimmune bullous diseases? It is based on there are four pillars in the diagnosis of AIBDs. The first pillar is clinical features. Second pillar is histopathological examination. Third pillar is direct immunofluorescence. And the fourth pillar is serology. So let us know the clinical features of these conditions. So coming to the intraepidermal conditions, the prototype of intraepidermal AIBD is pemphigus, where patient presents with mucosal lesions initially in pemphigus vulgaris. So as shown in these photographs, you can see here there's a lot of erosions on the palate, crusting of the lips. So initially, these people will go to various doctors, including dentists, because they will mistake these conditions for other common causes of oral ulcers, such as upper stomatitis. After a latent period of about 6 months, they develop skin lesions, which takes the form of flaccid blisters in the skin, mostly seen over the scalp, face, and upper part of the body. These blisters will rupture to form erosions, as shown here, and these erosions will spread peripherally to cover larger areas of the body. So this is the classical presentation of pemphigus vulgaris. On the other hand, the second common type of pemphigus is pemphigus foliaceus, which is considered as a superficial form of pemphigus, where it is very difficult to find a frank erosion here. Patient often presents with scaling and crusting, mostly affecting the seborrheic regions of the body. Sometimes this can be generalized, leading to exfoliated dermatitis or erythroderma. So this type of scaling, where there is a sort of peripheral rim of scales as shown here. So this is very classically seen in case of pemphigus foliaceus. Other uncommon forms of pemphigus also one should be aware of. One such form is called pemphigus vegetans, which is a variant of pemphigus vulgaris, where patient will have vegetative plaques, mostly over the axilla, groin, or submammary region in females. So these lesions will have vegetative lesions. Pemphigus erythematosus, which is otherwise known as senior Usher syndrome, is a variant of pemphigus foliaceus, where patient will have a cell-like rash, especially on the malar region of the body, as shown here. They will have scaly and crusted erythematous plaque in the malar region that is often confused for systemic lupus erythematosus. Pemphigus herpetiformis, as name suggests, will have grouped lesions. So, like herpes, they will have vesicles which are arranged in groups, and this form of pemphigus is very itchy in nature. IgA pemphigus is a rare form of pemphigus, where two different forms have been described based on histopathology. One is called subcorneal pustular dermatosis, like IgA pemphigus, where the blister formation occurs just below the stratum corneum. On the other hand, the other type of IgA pemphigus is called IEN type, or intraepidermal neutrophilic type, where the cleavage occurs in the mid-epidermis. How different is IgA pemphigus from other type of pemphigus is that this type of pemphigus is predominantly mediated by IgA in contrast to other type of pemphigus which are IgG mediated condition. Paraneoplastic pemphigus occurs in the setting of neoplasm, mostly lymphoreticular malignancies, and these people will have very distinct clinical appearance in the form of recalcitrant mucositis and polymorphous skin eruptions, which includes lichenoid lesions or erythema multiforme-like lesions, or sometimes like bullous lymphoid-like lesions. Various drugs also can cause pemphigus-like eruptions, most importantly ACE inhibitors, rifampicin, and D-penicillamine. So these come under the category of drug-induced pemphigus. So these are often considered as major forms of pemphigus. Now, moving on to subepidermal conditions. Subepidermal conditions, clinically, they present with TENS, especially bullous pemphigoid is the prototype of these conditions. Clinically, they present with TENS blisters, in contrast to pemphigus, where you get flaccid blisters. The blisters are tense in nature here because they are subepidermal in cleavage. So these lesions are usually seen over the flexure aspect of extremities, in the groin fold, or in the lower abdomen. When compared to pemphigus, where oral lesions are very common, especially in vulgaris, oral lesions are not that common in case of bullous pemphigoid, though it occurs less frequently in about 30% of the patients. We need to be aware of atypical presentation of bullous pemphigoid. Studies have shown that at least 20% of bullous pemphigoid patients will not have blisters at all. This is especially true in case of certain drug-induced pemphigus, where they can have eczematoid picture or prurigo-like lesions without any blister formation. So that is also we need to be aware of. So the diagnosis of bullous pemphigoid is not very straightforward because there are a lot of other subepidermal autoimmune bullous conditions which can mimic bullous pemphigoid. So that is why one need to evaluate these patients using all the available laboratory techniques so that we can arrive at the precise diagnosis. Bullous pemphigoid can mimic other subepidermal AIBDs, including linear IgDs, IgEBA, or epidermolysis bullosa or mucous membrane pemphigoid. So the next condition is called epidermolysis bullosa acquisita, though it occurs relatively in young population compared to bullous pemphigoid, which is usually seen after the age of 60, whereas EBA occurs in relatively younger age group. Two peaks have been described, one in the second decade of life and other in the seventh decade of life. Most importantly, two important phenotypical presentations of EBA have been described. One is called classical type, where the blisters are present mostly over the trauma-prone areas. So this phenotype of EBA is called mechanobullous type of EBA, which invariably heals with scar formation, and then there will be milia formation. On the other hand, inflammatory phenotype of EBA, which accounts for about 2/3 of cases of EBA, mimics any other subepidermal bullous conditions such as bullous pemphigoid, MMP, linear IgDs, or positioning period. So that is why we need to investigate this patient and use the laboratory techniques to arrive at the precise diagnosis. Linear IgDs is a very distinct subepidermal autoimmune bullous disease where there will be deposition of IgA, linear IgA deposition along the dermoepidermal junction, often showing string of pearl appearance or cluster of jewel appearance as shown here. Though this appearance is characteristic of LABD, it is not specific. It can be seen in various other vesiculobullous diseases also. So most of the time, the clinician will, if you give a diagnosis of bullous pemphigoid in these patients, clinician will call you and tell you that patient had a cluster of jewel appearance. So please inform them that cluster of jewel appearance can be seen in other subepidermal conditions also, and it is not specific for linear IgA disease. This is one of the new conditions that has been described. It is almost like now 30-year-old condition, which is called anti-P200 pemphigoid. So again, clinically, it resembles bullous pemphigoid or linear IgA disease. The autoantibodies in these conditions target a very distinct protein which is present in the lower lamina lucida region, which is called laminin gamma 1 or P2, which weighs about 200 kilotons. So that is the target of this condition. So we have described the first report of this condition from India in 2017. So this is, and nowadays we are seeing more and more of these conditions. It requires little advanced laboratory techniques to arrive at the diagnosis, but it can be done using immunofluorescence techniques. Mucous membrane pemphigoid is a very distinct entity, very distinct type of subepidermal AIBD. As the name suggests, this condition is confined predominantly to the mucous membrane. About 30% of these patients also will have skin lesions, but most of the time it is confined to the mucous membrane. It can involve the oral mucosa, followed by conjunctival mucosa, nasal or genital mucosa. Any mucous membrane can be affected. So especially when they have both skin lesions as well as mucosal lesions, that distinction from bullous pemphigoid may be a challenging one. So that is why we need to do investigations in these patients because of the clinical overlap of these conditions. So what the first step in any centers in our country is histopathological examination. So what are the histopathological changes in these conditions? So histopathology will help us to look at the level of split. As we discussed earlier, if you find a subcorneal split in your patient of vesiculobullous disease, you will consider the possibility of pemphigus foliaceus, pemphigus erythematosus, or IgA pemphigus of SCPG type. On the other hand, if the split occurs in the mid-epidermal level, then you would think of intraepidermal neutrophilic type of IgA pemphigus. Suprabasal split, on the other hand, is classically seen in pemphigus vulgaris as well as in paraneoplastic condition. So this is about intraepidermal conditions. On the other hand, when we have a patient who has subepidermal bullae, then we need to look at the predominant infiltrate which is present in the blister cavity. If the infiltrate is predominantly made up of eosinophils with poor mixture of neutrophils, then you are considering the possibility of bullous pemphigoid. Occasionally, it may be seen in anti-P200 pemphigoid or epidermolysis bullosa acquisita. On the other hand, if the infiltrate is predominantly made up of neutrophils, then you would consider the possibility of subepidermal conditions with neutrophil-rich infiltrate such as linear IgA disease, anti-P200 pemphigoid, epidermolysis bullosa acquisita, or bullous SLE. Certain conditions, you may not be able to see infiltrate at all. So you will have quasi-inflammatory infiltrate. The classical example for this being epidermolysis bullosa acquisita. Occasionally, bullous pemphigoid can also have very little inflammatory infiltrate. So you have two variants of bullous pemphigoid histopathologically. One is called cell-rich type, another is called cell-poor type. So in cell-rich type, there's a lot of eosinophils in the inflammatory infiltrate. Clinically, these patients will have an urticated background or around the bulla or the blister arises from an urticated background, and those patients will have a lot of inflammatory infiltrate comprising of eosinophils. On the other hand, bullous pemphigoid patients may also develop blisters without any surrounding erythema, and those subset of patients will not show inflammatory infiltrate in the blister cavity. So you have post-inflammatory infiltrate. So we also need to be aware of non-specific finding, which accounts for 20% of bullous pemphigoid patients. And in this subgroup of patients, the histopathological findings also will be atypical. So we need to move on and do immunofluorescence test to confirm the diagnosis. So as I told earlier, bullous pemphigoid patient will have a prodromal phase of urticaria, which so this is one of our patients who had urticated background, and then he also had a few tense blisters at the periphery of this urticated background. If you take biopsy from these lesions, so what do you see? You will not see subcorneal, subepidermal blister, but then you will see spongiosis, and then there is plenty of eosinophils in the spongiotic cavity. So this particular appearance is called eosinophilic spongiosis, which is seen, which is not specific for bullous pemphigoid, but then it is one of the conditions where you can get eosinophilic spongiosis. Another important clue to the diagnosis of eosinophil, especially in the early stage of bullous pemphigoid is the stacking of eosinophils along the dermoepidermal junction. So that will tell you that this is probably prodromal phase of bullous pemphigoid. Having said that, one need to be aware of the loopholes in the diagnosis, histopathological diagnosis of these conditions. This particular study from Japan has where they have studied about 55 patients of pemphigus, and you can see here in pemphigus vulgaris, suprabasal cleavage is seen in only 3 patients of pemphigus vulgaris. Majority of them showed cleavage throughout the epidermis. On the other hand, in pemphigus vulgaris, in this particular study, showed subcorneal split only in 6 cases, whereas it was in different layers of the epidermis in rest of the patient. On the other hand, the another study from US has shown that in subepidermal conditions, only about 54 patients had showed subepidermal clefting. So there is a lot of discordance between the clinical presentation of clinical diagnosis and histopathological report. This possibly could be due to the site of biopsy or the age of the lesion. But then some patients, when they present, they may not have an early lesion to take a biopsy from. So they might lead to wrong report. So that is why we need to do immunofluorescence in all these patients. So immunofluorescence is considered as the gold standard test in the diagnosis of these conditions. It is also useful in other diverse conditions such as lichen planus, vasculitis, connective tissue diseases, or porphyria and amyloidosis. I'll give a brief overview of immunofluorescence test for you. So what's the principle of immunofluorescence? Immunofluorescence in autoimmune bullous diseases, the autoantibodies are developed against self-antigens. So let us imagine there is an antigen in the skin against which autoantibodies are developed, and that leads to the disease process. Now, we want to demonstrate these antibodies that is bound to the tissue antigens. So for that, we select anti-human immunoglobulin that is developed in the rabbit. And when this particular immunoglobulin is stacked with the fluorescent dye, this reaction can be visualized under microscope. So this is the principle of direct immunofluorescence. Now, the types of immunofluorescence test, there is a direct immunofluorescence test where we want to demonstrate the tissue-bound antibodies. It will tell us the site of immune deposits, whether it is present in the epidermis or in the dermoepidermal junction. The pattern of staining also will be visible, whether it is linear staining or granular staining, and type of immunoreactants. Based on this constellation of these findings, we arrive at the diagnosis. If you want to demonstrate the circulating antibodies, we draw patients' blood and then separate the serum and look for antibodies. And that particular technique is called indirect immunofluorescence. So in direct immunofluorescence, you are looking for the tissue-bound antibodies. You take skin biopsy. In case of indirect immunofluorescence, we're looking for circulating antibodies using patient serum. And the other technique of immunofluorescence is called salt split technique, which can be done by both direct as well as indirect technique. So the ideal site of biopsy for all these conditions is perilesional skin, because in the lesional skin where there is a blister, the immunoreactants would have been already destroyed or digested. So it is always preferable to take biopsy from the perilesional skin in case of suspected autoimmune bullous diseases. On the other hand, in other conditions such as vasculitis, lichen planus, or in connective tissue diseases such as DLE, we prefer to take biopsy from the lesional skin. So punch biopsy is the technique that we always use in the clinic. In pemphigus, direct immunofluorescence will show you this typical pattern, which is called fishnet appearance or chicken wire appearance, and this is predominantly seen with IgG class of immunoglobulin. C3 deposits also can be seen in about 50% of the patients, especially in the active phase of the disease. It is uncommon to detect other class of immunoglobulins such as IgA or IgM, which may be seen in about 20 to 30% of the patients. So this is the classical appearance, intercellular staining of the epidermis, giving a fishnet appearance in case of pemphigus group of conditions. Now, the next question is, can we differentiate pemphigus vulgaris from pemphigus foliaceus based on immunofluorescence technique? So these are the two common conditions, and they account for about 90% of pemphigus in the clinical practice. So clinician always wants to know, is it vulgaris or foliaceus? So the answer should be direct immunofluorescence is not the test to differentiate these conditions, because the pattern of staining in both these conditions is same. However, occasionally one will be able to find this kind of classical presentation where there is a suprabasal split. You can see here basal layer in the blister, in the floor of the blister cavity, and the entire epidermis forms the roof of the split. So this is a classical case of pemphigus vulgaris. On the other hand, in pemphigus foliaceus, the staining is more intense in the upper epidermis. As we go down to the basal layer, the intensity of staining comes down. This is because the antigens, distribution of antigens are different in these two conditions. Desmoglein 3 is the predominant antigen here in pemphigus vulgaris, whereas desmoglein 1 is the predominant antigen here in pemphigus foliaceus. So that results in this differential deposition of immunoreactants. But in general, please remember that immunofluorescence is not the test to differentiate these two conditions. In a certain subgroup of patients, in addition to the presence of intercellular staining in the epidermis, you also will be able to see deposition at the dermoepidermal junction. Two such conditions are paraneoplastic pemphigus, where you will see intercellular staining in the epidermis and a linear staining of dermoepidermal junction. So when we see this kind of dual deposits, always cross-check the clinical findings and see if the patient fits into the diagnosis of PNP. On the other hand, in pemphigus erythematosus, which is a combination of pemphigus and lupus erythematosus, you will get intercellular staining as well as granular staining of dermoepidermal junction. So again, these patients will have features of both pemphigus as well as lupus erythematosus, both clinically as well as immunopathologically. So, to summarize the immunofluorescence finding in intraepidermal conditions, so you will get two different patterns. One is intercellular staining, or sometimes intercellular plus BMZ staining. So when we see intercellular and BMZ staining, these are the only two possibilities: paraneoplastic pemphigus or pemphigus erythematosus. But then clinically, these two conditions are very distinct. There is oral lesion here. There is no oral lesion in this condition. So you have a diagnosis in your hand. So, however, to confirm the diagnosis of PNP, we might have to do indirect immunofluorescence on rat bladder. We might have to do ANA if we're suspecting pemphigus erythematosus, or immunoblotting to detect various antigens in case of PNP. On the other hand, when the finding is only confined to epidermis in the form of intercellular staining, so we have to check whether it is with IgA. In case if it is exclusively seen with IgA, then the diagnosis is IgA pemphigus. On the other hand, if it is seen predominantly with IgG, with or without C3, then the diagnosis would be either pemphigus vulgaris or foliaceus. Then we need to do serological examination such as indirect immunofluorescence and ELISA to further categorize these patients. So coming to subepidermal AIBDs, the classical findings, direct immunofluorescence finding in this condition is linear staining of basement membrane zone in a thread-like fashion as shown here. So on the other hand, some patients with dermatitis, especially in dermatitis herpetiformis, will not show you linear staining. Instead, they will show granular staining like this, which is mostly accentuated over the tip of papillae. As you come down the papillae in the ridges, the staining becomes less intense. So this is classical finding of dermatitis herpetiformis, where you will get granular IgA staining. So this is the common linear staining of BMZ is the common finding in subepidermal conditions, and that occurs because of antibodies target the proteins in the dermoepidermal junction, and all of them will show you linear staining of BMZ. Now we have at least 6 different conditions, and you want to differentiate these 6 conditions. these are the antibodies that they target. And for that, there is a technique which is called serration pattern analysis. So serration pattern analysis is a technique which is based on direct immunofluorescence findings, where two different staining patterns have been described. One is called N serration pattern and the other is called U serration pattern. So you can see here, this is the U serration pattern, where the the top of arc are open, whereas in N-serrated pattern, the bottom of the arc is open. So this is like an N-shaped distribution, and this is sort of U-shaped distribution. So when you say N-serration pattern, this is seen in all subepidermal conditions except the epidermolysis bullosa acquisita. So U-serration pattern is almost classical of EBA, whereas N-serrated pattern can be seen in various other conditions. And this is our paper where we have described these techniques in Indian patients. So that will come to the last pillar of our diagnostic algorithm, that is called serological diagnosis. And serological diagnosis is very important in the diagnosis of these conditions because, as we understand, histopathology and direct immunofluorescence has got its own limitation in the diagnosis. So it will not be able to clinch the diagnosis in all these conditions precisely. So we need to do serological investigations. So what are the various, what are the advantages? That serological investigations will help us to detect the circulating antibodies. So they give information about the specific target antigens, and that will also give information about the antibody burden in the body. So this will have prognostic implications. So when you diagnose a patient and you start the patient on treatment, you want to know what's happening to the antibody burden in the body. So you can just draw blood and send the serum for examination. We will know the antibody burden in the body. In case of subepidermal AIBDs, it helps in the subcategorization of these conditions, as we see in the subsequent slides, and it also helps in the detection of target antibodies, antigens. So what are the techniques that are available for this serological diagnosis? One is called indirect immunofluorescence, which is based again on indirect immunofluorescence microscope, ELISA, and immunoblotting. So these are the three techniques that are available, but unfortunately, immunoblotting is not available in India at present, whereas the commercially available kits are there in many centers, and it's useful in the diagnosis of certain conditions, at least bullous, pemphigoid, and pemphigus group of diseases. So the first serological test is indirect immunofluorescence. The sensitivity of indirect immunofluorescence to a great extent depends on the substrate used. Now, what is this ideal substrate? In case of pemphigus vulgaris, if you're suspecting pemphigus vulgaris, monkey esophagus is the ideal substrate. If you're suspecting paraneum, pemphigus foliaceus, the ideal substrate would be normal human skin. On the other hand, if you're suspecting paraneoplastic pemphigus, the autoantibodies in paraneoplastic pemphigus target transitional epithelium. So we need to use the transitional epithelium that is usually obtained from rat bladder. In all subepidermal AIBDs, the ideal substrate for indirect immunofluorescence is salt split techniques, where we split the normal human skin using 1 molar sodium chloride, and then you look at the pattern of staining. So this is the monkey esophagus slide. You can see this is available commercially now. So you can see the intercellular staining of epithelium in with IgG. So that confirms the diagnosis of pemphigus. So in subepidermal conditions, as I told you, the ideal substrate would be salt split skin. So how do you do the salt split skin? You have to incubate the normal human skin in 1 molar sodium chloride and for 24 hours. And after 24 hours, you gently tease the skin, and then the weakest link between the epidermis and dermis is this lamina lucida. So when you tease the skin, there is separation of the epidermis from the dermis, at the level of lamina lucida. So as a result, few antigens will relocate to the roof of the split, whereas few antigens will remain at the base of the split. So if a patient's antibodies are targeting these group of proteins, then they will go to the roof of the split. On the other hand, if they are targeting these proteins, then they will remain on the dermal side of the split or the floor of the split. So accordingly, you have a roof staining pattern and a floor staining pattern. Roof staining pattern is classically seen in these conditions, bullous pemphigoid, mucous membrane pemphigoid or linear edge disease, whereas floor staining pattern is classically described in epidermolysis bullosa acquisita, a type of MMP which is called anti-laminin 332 type of MMP, P200 pemphigoid, and bullous SLE. Now, your further diagnosis is based on the direct immunofluorescence finding, Serration pattern analysis, and in the result of indirect immunofluorescence. So when you put all these informations together, you can arrive at the precise diagnosis in these conditions. So your patient with subepidermal bullous condition can either show a linear BMZ staining or a granular IgA staining. The granular IgA staining is almost confirmatory finding of dermatitis herpetiformis. Then you can sign this off telling that this is BH. But on the other hand, if there is a linear BMZ staining, you have to check whether it is seen exclusively with IgA or it is seen with IgG with or without C3. If it is, then the next step would be to do indirect immunofluorescence on salt split study to check if there is epidermal staining pattern or dermal staining pattern. So if it is with IgG and if there is epidermal staining pattern or the BMZ band is going to the roof of the split, then it is diagnostic of pemphigoid group of disease or bullous pemphigoid. On the other hand, as we learned now, double staining pattern can be seen in these conditions. So again, the result of immunofluorescence will help you. In EPA, you will get Serration pattern analysis is useful in these conditions. So indirect immunofluorescence showing dermal staining pattern, Serration pattern showing serration, then you are thinking of epidermolysis bullosa acquisita. On the other hand, all these conditions will, even though they show floor staining pattern, Serration pattern will give you Serration pattern similar to bullous pemphigoid. So you have your diagnosis confirmed based on a combination of indirect immunofluorescence and Serration pattern analysis. I understand that this technique is little bit difficult to understand. So I'm trying to sort of give an overview of these findings. Now, we have learned that different conditions will require different substrates. And in a given center, all the substrates may not be available for routine use. So Immunofluorescence has come out with a simple techniques which they call it as multiplex IF or mosaic biochip technique. So that is available commercially now. So if you have indirect immunofluorescence, you can procure these slides and then perform indirect immunofluorescence. I will let you know the advantages of these techniques. On the other hand, multiplex ELISA also has come, is available in the market now, and many centers, including ours, are using these techniques now for the quick diagnosis of this condition. Now, this is how the multiplex indirect immunofluorescence slide looks like. It has got 5 or 10 incubation fields, and each incubation field has got 6 windows. So these 6 windows are contains different substrates or proteins. So this is monkey esophagus. This is salt split skin. This is desmoglein 3. This is desmoglein 1. This is BP180. and this is BP230. So the advantage of this technique is just have to add one drop. These are the ready-made slides. You need not take any sections. You just have to draw patient's blood, separate the serum, and just add one drop of serum in 1:10 dilution to one of these fields. So you can simultaneously run 5 or 10 patient serum, and that will tell you that will help you in the diagnosis of common autoimmune conditions. So, for example, in a patient of pemphigus, for example, he will show you intracellular staining in monkey esophagus, and this is the desmoglein 1 positivity, and this is the desmoglein 3 positivity. So, when you see these three, you know that this patient is suffering from pemphigus. On the other hand, when in a patient of bullous pemphigoid, that will show you a roof staining pattern on salt split skin. This is BP 180 positive, and this is BP 230 positive. So it will not only tell you the pattern of staining on tissue sections, it also will help in the detection of autoantigens in these conditions. So that is the advantage of performing these mosaic biopsy techniques. However, at present, they are very expensive for routine use, and most of our patients, especially when you compare it with the conventional technique, so especially it may not be suitable for routine use in many centers. So to conclude my talk, autoimmune bullous conditions are a heterogeneous group of conditions with a lot of clinical pathological overlap, as we learned now. Atypical presentations can be a challenge in the diagnosis, both clinically as well as histopathologically. Laboratory investigations are essential in these conditions. If somebody says that they can diagnose all autoimmune conditions based on the clinical morphology, that is not right, because a lot of overlapping features will be there, and only investigation findings will tell us what exactly is the underlying disease. What we need to understand here is laboratory tests are supplementary to each other, and they are not substitute. It is not that you can you need not do histopathology and then straight away go for immunofluorescence, or you can bypass biopsy and straight away go for serological test. You are likely to be missing at least 5 to 10% of cases. With all these investigations, direct immunofluorescence remains the gold standard in the diagnosis of these conditions. It will help us in the detection of tissue-bound antibodies. Serology will further help to identify the target antigens and should be performed whenever it is available, whenever the techniques are available. So with this brief presentation, I would like to thank IIPM Kerala again, and I will be happy to take any questions.
Thank you, sir, for the wonderful presentation. So we can go to the question and answer session now. So there's a question from Dr. Rinku. Is the DIF finding in pemphigus erythematosus similar to DLE?
In DLE, you will not get intercellular staining. In pemphigus erythematosus, you will get intercellular staining also, and in addition to granular staining of BMZ. So, pemphigus erythematosus is a immunopathological overlap of pemphigus as well as discoid lupus erythematosus or lupus erythematosus.
So, Mindray team, can you please unmute the participants? Maybe some of them have to ask questions directly.
Yeah, sure, ma'am. Mr. Nikhil,
Any more questions?
Yes, ma'am. Yes, ma'am. Yeah.
can you please unmute all? I mean, if anybody wants to ask the questions.
Yeah, madam. One by one, I'll have to do. I'll just unmute everybody. Yeah.
Yeah, sure. Thank you.
I have done, ma'am. Everybody, like one by one, I'm doing.
So there is one question on the experience of inherited
Plus
bullous
this
disorder.
bullous.
So we are talking about epidermolysis bullosa, hereditary epidermolysis bullosa here, where a different technique called immunofluorescence antigen mapping is used, where we use monoclonal antibodies specifically against some of the mutated proteins like type 7 collagen, laminin 332, and all. But unfortunately, it is most common type of hereditary EB in our setting is EB simplex, where these techniques are not that helpful. But if somebody is suffering from dystrophic epidermolysis bullosa or laminin variant, that is Hurlitz's junctional epidermolysis bullosa, then we will be able to diagnose based on antigen mapping. That's a different technique. It is not direct immunofluorescence. It is called antigen mapping, where we probe the skin, patient skin, with different monoclonal antibodies such as laminin 332 or type 7 collagen. If the facility for mutation analysis is not available, then probably you can do antigen mapping, or it also gives it direction. Nowadays, they do whole gene sequencing, so that question of selecting the gene for mutation analysis doesn't exist, because entire whole gene sequencing is done in the genetics. So,
Dr. Shahina.
Meantime, we have one on question in Q&A. Can we take that?
Sure.
The question is, if we get only C3 along BMZ, it is diagnosed of C3 dermatosis?
C3 bullous pemphigoid patients. Bullous pemphigoid, if you look at the pathogenesis of bullous pemphigoid is a complement-mediated disease. So, in our experience, there is complement deposition in all patients of bullous pemphigoid. So, a linear deposition of C3 along the dermoepidermal junction is diagnostic of subepidermal condition, including bullous pemphigoid. There is one report from Japan where the authors have described granular C3 bullous dermatosis. But then that is the only report that is available in the literature at present. That was reported some 10 years back. I think it is in 2016 or so. There is no further report of similar conditions from any centers in the world. This C3 deposition along the dermoepidermal junction, in my experience, is not specific for any conditions, any specific conditions. It is just a manifestation of itchy skin. So if you take biopsy from any of the chronically itchy skin conditions such as prurigo or prurigo nodularis, they will have this kind of C3 deposition along the dermoepidermal junction. You should not give much emphasis or importance to granular C3 deposition. So in case of bullous pemphigoid, most of the time you will be able to find sort of extension of these immune deposits along the basal keratinocytes. So that will clinch the diagnosis. In C3 deposition, granular deposition, you will not see that findings. So at present, I don't think you need to give much importance for granular C3 deposits along the dermoepidermal junction. Having said that, a linear C3 deposition, definitely, yes, it's a diagnostic view of subepidermal conditions, including bullous pemphigoid. And in some conditions such as pemphigoid gestation, which is seen in pregnancy, C3 is the only immunodeposits that is seen. In certain conditions such as these are some of the soft clues that will tell us. In epidermolysis bullosa etc., in general, there will be multiple immune deposits. So you will be able to see linear BMZ band with IgG, C3, IgA. So when we have this panel of immunoreactants at dermoepidermal junction, we always consider is it EBA, and then we need to do salt split to confirm whether it is epidermal staining or dermal staining on salt split skin. On the other hand, in bullous pemphigoid, most of the time it's a very strong C3 VMZ band and a very faint IgG VMZ band.
Ma'am, shall I show the last slide or we are waiting for some other questions?
Dr. Shahina, she had raised her hand. Would you please unmute her?
Ma'am, everybody is unmute. Whoever wants to ask questions can unmute themselves and ask.
Okay.
I've given the permission to speak to everyone. The audio.
Okay, thank you.
Lakshmi madam.
Some people are still raising the hands. Ma'am, you can just ask your question, Dr. Vijayalakshmi, ma'am.
Hello.
Yes, ma'am. You are audible. You are audible.
Fine. Good evening, Dr. Rao. Hello.
Yeah, good evening, madam. Tell me.
Yeah, your presentation was excellent. Now, I've got two questions to ask. One is a very simple question. You said, you showed us two papers, right? Where there's a discordance between the histological pattern and the clinical manifestation, right?
Yes, ma'am.
And you have mentioned that DIF is mandatory. But suppose you have a center where you cannot do a DIF, then how do you proceed under such circumstances? If there is a discordance.
DF, if the facility for DF is not available in your center, you can still send the biopsy to a center where DF is done. So there is a transport media. Which I told in the presentation, but I think most of the residents are aware of transport media. So you can still ship it to the center where DF is being done. So that is one thing. So again, based on any of these tests, can you make a precise diagnosis of autoimmune bullous condition? I am not sure, madam, because even in our experience, though we are doing DF since decades now, and then we do histopathology also, there is a lot of discordance between DF findings and histopathological findings, because maybe the age of lesion when the patient presents to us, they probably a subepidermal condition probably is in the phase of healing, and it has become intraepidermal blister. So even in a classical case of bullous pemphigoid, where DF is showing bullous pemphigoid like picture, histopathology has shown intraepidermal blisters. Probably that is the tricky part of histopathological examination. But if the biopsy is done properly, if somebody can identify the fresh lesion and take it from that lesion, then probably histopathology is good. Having said that, then histopathology has got its own advantages. For example, in a type of, there are some reports of cutaneous pemphigus vulgaris where a patient will not have any oral lesion. They will have just cutaneous lesions. So studies have shown that these patients still have this suprabasal cleavage, even though they don't have the oral lesions.
Okay, one more question, Dr. Rao, is, you mentioned about bullous pemphigoid, and you mentioned there are 6 proteins which are involved, right?
Not in bullous pemphigoid alone, it is in all pemphigoid group of disease. In subepidermal conditions, there are 6 different proteins.
Proteins which are involved. So you said that these proteins in that finally you said in indirect in immunofluorescence, or you'll be able to target the particular antigens. Am I right?
Yes.
Yeah. So my question to you is this: that but when targeting is the line of Hello.
Yes, madam. Yes, madam. Continue. Please continue, madam.
Right. So, my question to you is this: that when you want, I mean, is there any particular? I mean, does this have any? I mean, from the treatment point of view, is there any difference in the different type of antigens which are present there in the particular the bullous lesion that you want
I
to
think,
target
yeah,
with antigen? Or
very,
is it
very valid question. So, what is the point in identifying all these proteins if it doesn't make any difference from prognostication or treatment perspective? We know that certain bullous diseases are very resistant to treatment. That is one. EBA, for example, is very difficult to treat condition compared to bullous pemphigus. Bullous pemphigus, the first line treatment is topical steroids. We can manage some of these conditions with giving antibiotics such as doxycycline, or sometimes dapsone can help. Whereas epidermolysis bullosa acquisita is very difficult to treat. They are very resistant to treatment resistant. The second important parameter is some of these conditions are associated with internal malignancies. For example, anti-laminin 332 type of mucous membrane pemphigus, about 25% of these patients, 1 in 4 patients, will have an underlying internal malignancy. So we want to know which patient we need to screen for internal malignancies. So that can be guided by performing these tests. And if your patient is showing that particular target antigen, and that is the time when you do all the necessary investigation and make sure that this particular patient is not suffering from any of the internal malignancies. So to screen for the malignancies and to prognosticate this patient, we need to identify the target antigens.
okay?
Did it answer your question, madam?
Okay, so that means there's no difference in the treatment. Only thing is maybe resistant treatment or from the prognosis point of view. Am I right?
Yeah, broad perspective, it is all, they are all autoimmune conditions. They are all
Yeah.
immune-mediated conditions.
Yeah.
So we follow sort of similar guidelines for all these conditions, but then certain conditions respond better to certain particular medicines compared to other medicines.
Okay. One more question I got. It's okay. Now you mentioned about the salt skin split, right?
Yes.
And in the algorithm, you have mentioned that at point comes where you need to do it, salt split, to find the roof binding or floor binding.
Yeah.
Is it routinely done, or in your?
We do it routinely, madam, for all our patients. We do it routinely because, as I told, we want to like there's a lot of clinical overlap between these conditions, and sometimes they don't respond to the same line of treatment. So we want to know in the beginning itself what exactly is the diagnosis. That is why we do salt split technique. It's very simple technique, very easy to identify the findings also. So we do it routinely for all our patients with subepidermal conditions.
Okay.
It
Thank
is
you
not
so much.
required for intraepidermal, but it's required for subepidermal condition.
Okay. Thank you so much, Dr. Rao.
Welcome.
Thank you, sir.
There is one more question in the chat box. Serology of desmoglein in pemphigus and BP 180 serum can also be done. Serology, if I understood this question, serology for both for all proteins we can do serological examination. Some of them are available commercially. For example, desmoglein ELISA can be done. Both desmoglein 1 and 3 are available. BP 180 and 230 ELISA kits are available, and we are doing it routinely for all our patients, and that will help in the prognostication. So a high antibody titer indicates patient would require aggressive management. If the antibody titer is not very high, then probably we don't consider sort of monoclonal antibodies such as rituximab for these patients. But that is very important. And when you treat the patient, the antibody levels will come down. So then we monitor them periodically, once in 3 months or 6 months, and check what is the status of these antibodies. With effective treatment, the antibody titers will become negative. And once it is negative, again, you do it after 3 months or 6 months. Then if it is again becoming positive, that indicates that the patient is going for a relapse. So we have seen that the antibody titers becomes positive first before the clinical relapse. So antibody immunological relapse occurs earlier than clinical relapse. So that is why we need to monitor these patients and identify which patient is going to develop clinical relapse. That is why we do it routinely for all these patients. The technique may be different. The LSI is the standard technique, and commercial kits are available for LSI. At least in India, now we have both Desmogain 1 and 3 LSI kits and BP 180 and 230 LSI kits. Type 7 LSI is not yet licensed in India, but then Mosaic biochip is the other technique which will help to detect these antigens. So it is a very simple technique. As I told in the beginning, you just have to add one drop and then look for the presence of these antigens. But it doesn't give much information because we are doing only in 1 in 10 titers. So 1 in 10 dilution only. So it will just tell you that whether the antigens are targeting this particular protein or not. Apart from that, if you want to quantify the antibody burden, then you need to do ELISA.
Well, just one doubt. All vesiculobullous lesions, whether it is intraepidermal or subepidermal, management is same. The difference is based on the prognosis or resistant to treatment.
Management is not same actually. For example, in all IgA-mediated condition, the first line treatment is dapsone. We don't give steroids. So that can be detected only by doing immunofluorescence, whether the patient there is IgA deposition or not. If there is an exclusive IgA deposition, whether it is dermatitis herpetiformis or linear IgA disease, dapsone is the drug of choice. Whereas in IgG-mediated condition, if it is bullous pemphigoid, we usually will not be very aggressive in our approach. We sometimes give low dose of steroids, or sometimes we give topical steroids, or now doxycycline also is one of the treatment option for bullous pemphigoid. So these are the permutation and combination that we do. Whereas in case of pemphigus, pemphigus is very life-threatening condition. So if you don't treat it aggressively, they're not going to survive. So it's as simple as that. So we are very aggressive in the management of pemphigus. So we start them on high dose of steroids, and now rituximab, which is a monoclonal antibody against CD20, that is the first line treatment. So before we initiate this treatment, it is always good to confirm the diagnosis by doing all these advanced immunological tests. So that is why we want to do all the immunological tests. If something goes wrong tomorrow, then you should not be held responsible for the wrong diagnosis. So that is why before you consider all this newer treatment, it is always better to confirm the diagnosis and do all the necessary investigation.
Thank you, sir.
Shiny.
Okay. So I think no more questions. Okay. So on behalf of IAPM Kerala chapter, I would like to thank Dr. Raghavendra Rao, Professor, Department of Pathology, KMC Manipal, for the excellent talk on the approach to vesiculobullous lesions of the skin. Vesiculobullous lesions, as I said, can pose significant diagnostic challenges depending upon the site of the biopsy and also in the case of older lesions. But Sir's talk has provided a systematic and algorithmic approach in correlating clinical features and also in histopathology and DIF findings. And that will help us to reach an accurate diagnosis. So I'm sure all of us have benefited from this talk. Thank you so much, sir. And special thanks to Mindray team for organizing this webinar. And thanks to all participants for contributing to success of this event. And a reminder, there will be a quiz based on this webinar series, which will be conducted during the Kerala chapter meeting at Calicut on 9th February. And we are looking ahead. We invite you to join the next webinar on 24th January 2025. That is Approach to Granulomatous Dermatitis by Dr. G. Nandakumar, who is a consultant pathologist in the Cosmopolitan Hospital, Trivandrum. So thank you, everyone, for your valuable participation and support. Thank you so much.
Thank you. Thank you very much.
Thank you very much, everyone. And thank you, Dr. Rao, and thank you, Dr. Shaini, and the IAPM Dr. Kara team.
Thank you, everyone. Thank you, everyone. Ma'am, there is a feedback link we have shared. So if people give feedback, so we have idea at the end, how many have given a good start. So that will just pop up on your screen. Thank you.
Yes, sir. Thank you.
Thank you, sir.